Hello, and welcome to Make It So with Dr. Robert Groves, a podcast focusing on healthcare. Yes, I know there are a ton of podcasts focusing on healthcare. What we're trying to do is understand how we make it more affordable, more accessible, and how we simply make it better in every way. And that next step is how do we make it so? Now, I'm Chief Medical Officer at Promptwell, a healthcare company specializing in human engagement. Now, what we do at Promptwell is make it easier for you to get your message out to everyone so that they actually pay attention to whatever messaging you're sending, whether it's by email or by text. And we've demonstrated that up to twice the number of people will pay attention to your message, whether that's closing care gaps, prompting healthy actions, or simply making far more people aware of what you offer. If you want to learn more about Promptwell, then please visit our website at www.promptwell.com. That's PROMPTWELL.
The professional ideas and opinions expressed in this podcast are mine and do not reflect those of any current or past employers.
Welcome to the Make It So podcast, Dr. Robert Pearl. It's such a pleasure to talk to you again. I wonder if you could do us a favor and just give us a brief introduction. You've done so much that I'm sure you could take up the whole podcast, just giving us insights on what you do, but introduce yourself for the audience.
Well, I went to medical school at Yale, then I went to Stanford and trained to be a plastic and reconstructive surgeon. I focused on kids with cleft lip and cleft palate. After that, I continued to operate, but pursued an administrative course and became the CEO in Kaiser Permanente. And more recently, I left that job after 18 years, and I currently teach at the Stanford Graduate School of Business and Medical School. I write for Forbes twice a month. I host a weekly podcast called Fixing Healthcare, and I provided 40 keynotes last year. So got a lot of different irons in the fire these days.
Oh my gosh, you certainly do. You've got such a tremendous depth and breadth of experience. And, most recently we talked about your book, ChatGPTMD, and so I think it's appropriate to start out the conversation. There's been a lot in the news about AI lately. And I guess what I would ask is, anything about your perspective on AI changed since you wrote ChatGPTMD? What do you see differently and why?
When I wrote the book, it was published in 2023. I predicted that it would become, I'll say, almost ubiquitous in medicine, but that it would take 5 to 10 years. I was wrong. It's already happening in 2.5 years, twice as fast as I otherwise thought. And I'll give you one powerful example. The state of Utah will now allow a generative AI tool to monitor patients with chronic disease and to prescribe medication refills without a clinician oversight. I could not have thought. I thought I was being very aggressive when I wrote the book in terms of the time frame that I saw generative AI taking, but it's clear that I was overly conservative.
Yeah, I never would have imagined that development either. And how do you process that? Do you think it's as safe as having physicians do it? And there are lots of implications here. What about malpractice insurance? How is all that being handled in this particular circumstance?
Well, it's very fascinating because actually there's a malpractice insurance coverage that the generative AI tool has been given. So that opportunity already exists. What I believe is that generative AI will not only be as good as clinicians, but better. But the combination of dedicated clinicians with empowered patients and generative AI will be better, exponentially better than any of the three alone. And I think it's important that when we talk about generative AI tools, we have to put into the context of, well, how are clinicians doing today? There are 400,000 people who die every year in the United States from misdiagnoses, another 400,000 with permanent disabilities. And I believe that a generative AI tool can help alleviate that in two different ways. The first way is they can take a lot more information and details in. The average clinician has about 18 minutes per patient. By the time the individual addresses whatever is happening, they just don't have enough time to explore the problem in detail. They interrupt the patient within 15, 20 seconds of starting the office visit. And I think that that is how misdiagnoses happen. But I want to put a second spin on it, which is that we're going to also reduce the misdiagnoses because we're going to give clinicians back time. Think about how much we do that is simply automated. A generative AI tool will do it beautifully. A great example to me, and this is an interesting, also call it parallel path, is that for a long time when patients were given anticoagulation for atrial fibrillation, it had to be titrated to just the right dose. Give too little and blood clots form and they lead to strokes. Give too much, and what you see is that the patients have excess bleeding. And then someone said, well, why don't we have pharmacists do it? Lo and behold, not only did they do a great job, they did a better job than the physicians because they prioritized it higher. I think we're going to see the same thing with generative AI. And it'll be just as true whether we're managing hypertension, diabetes. It's going to be there every day. I mean, think about that. You see a patient with hypertension, you start them on a medication, and you say, I'll see you back in 4 months. What happens those 4 months? We have no idea. And why is that? Because there's no doctor who wants to get 100 blood pressure readings sent to the office every month or so. That's exactly what a generative AI tool can do. We know exactly what the parameters are for normal control. We know exactly the medications to be given. And the beauty of most of the technological solutions doesn't make the kind of mistakes that humans do when they get a decimal point wrong or somehow they misspell a medication or a pharmacist misreads it. This is going to be far more accurate. I don't believe it's going to be perfect. Don't get me wrong, but I want to compare it to what happens in medicine today. When I do that comparison, I think that we have a tremendous opportunity, and it literally is right around the corner.
That it's interesting because we've seen this with the self-driving cars, that when a self-driving car makes a mistake, everybody knows about it right away. There are all these, there's outcry, there's consternation. But when you compare the record of self-driving car to human beings, it's pretty darn good. Do you think we'll have the same, I guess I'll call that a cultural barrier with AI and medicine, where a mistake made by a machine is somehow much more horrible than a mistake made by a human being?
Absolutely. Absolutely. This is going to happen. It's embedded into our DNA. I mean, it's one of the cognitive biases that have actually been well described. As you said, the Waymos looked at the question of driving in San Francisco and did it on a per mile basis, and the mortality was 1/10, or the accidents were 1/10 as great as it is with human drivers, because humans get distracted, humans are on the cell phones. So a lot of reasons why the Waymo doesn't do those things. It's not that it's going to be perfect. It's just going to be a superior to what humans are doing. Think back to the ATMs. Neither you or I are old enough to remember to think back there, but read about it. And what you find is that people were very afraid. Will the money be taken? Will I ever see it back? How do I trust it? And today, people don't even blink. In fact, a lot of people just never deal with a human when it comes to the financial situations.
Very true. So, given that rapid evolution of AI, and given that those cultural barriers, will have to deal with them, but eventually we will, what advice would you give to the CEO or IT department at a major delivery system or a major physician group or Kaiser Permanente? What's deployment ready in AI today, and what would you say maybe wait a little bit longer on that?
I think what's here today are number one, administrative tasks, being able to help with billing and claims and pieces like that. And that's, I'll call it just the start. The second big thing that's here today is ambient listening. And increasingly, physicians are using the technology so that rather than staring at the computer screen, they can look at the patient and make sure they see what's going on. And those are good advances. There still is not the broad range of tools that we have. And I personally believe that we are underutilizing generative AI, large language models. So we have ChatGPT and Claude and the one from Google, Gemini,
Yeah.
ChatGPT, and Claude, the three big ones that are out there right now. Because I think patients could use them to be able to put data into place and be able to get an analysis and get some updates and figure out when things do need to change. And we don't, as clinicians, we're not doing that right now. I mean, think about that. Let's go back to that patient we just mentioned with hypertension. I'm going to see it in 4 months. But in that interim, we could have the patient already using the tools, taking a home blood pressure cuff, entering data in place, taking a monitor for blood glucose and being able to put the information in place and being able to figure out how things are going on if we were willing to change how we would then respond to the patient when they told us they were not getting better. And so would we be willing to set up a telemedicine visit and quickly change the medication so that they could get into control more rapidly? There are a lot of tools being developed right now. The one I described to you in Utah is an example of one of those tools. It's actually an interesting study done. Harvard, and we're talking about Harvard now. Let's start there. They found they didn't have enough primary care physicians. So what were they going to do? A patient calls up and says, I want a primary care physician. They have no one to offer. So what are they going to do instead? What are they doing instead? They have a system whereby basically a patient can enroll in a generative AI tool, which would then take all the information from the patient, would organize it, would establish the necessity for various clinical interventions, and that information then gets passed along to a physician who schedules a telemedicine visit. In doing that, they've shrunk the time from months down to days in order to get clinical expertise. By the way, the same approach is being tested at Mayo Clinic, Cedars-Sinai. And Cedars-Sinai did an interesting thing. They took the variety of information coming from patients and they tested it between the technology and humans. They gave the same information to both groups directly from the patient. Now, it was a small study. It was only about 500 patients. And what they found is that 10% more often, the technology gave a better answer, was able to discern how serious the problem was able to figure out the right diagnosis and the right treatment. And when there was agreement, that was great. But when there was disagreement, more often than not, the technology had the higher quality response as judged by independent observers. Now, I think we're at this transition point. I would not want to tell anyone right now that I know for sure that it's better. That's even necessarily as good as doctors. I think this still has to be tested and figured out. But to have I'll call it a negative opinion going in and assume that it can't be, I think is equally wrong. So I think right now the big thing people should be doing is experimenting with it, trying it. Pretend you're a patient. Put the information in place if you're a clinician. Or if you're a patient, put your information in place to the technology before you see your clinician, and then see how different the answers are. You know, sometimes I'll have a problem. I'm a big runner, I'm a big athlete, and I often have an orthopedic issue, and it's not my area of specialty. And when I put the information in place and then I call one of my orthopedic colleagues to get their advice, I'm amazed that almost always it's exactly the same. So I just think we need to be willing to be more aggressive in trying out these things, not yet turning them over, but figuring out and ask ourselves in all honesty, what's the most that we can do? Not what's the minimal agreement that we can make.
You know, that raises an interesting question that I'd love your opinion on. And do you see a day when ChatGPT, artificial intelligence, actually replaces the job of a primary care physician, which is primarily cognitive, right? It's not a procedural task. And so, you know, I've been hearing a lot lately on the news about predictions that AI is now replacing white collar jobs. If what you do is sit in front of a computer, then your job is at risk because AI is going to figure out how to do it better than you do very, very quickly. And that's a lot of jobs, obviously. Healthcare is a little bit different, but do you see a day when AI actually replaces the job of the physician?
I would like to reframe that question because I think it's the wrong lens to be looking through. Do I think that AI is going to replace physicians completely? My answer is no. But you have to ask yourself, okay, but what will it replace? I think a lot of chronic disease management, and I'm talking about in people who have only one or at most two problems that are reasonably well controlled, close to being controlled, and now we're trying to bring it into full control. I think the tool's not only going to replace what clinicians do, they're going to do it better. And they're not going to do it better because they're smarter. They can do it better just because they can do it more continuously. They can do it 24/7. They can link through Bluetooth devices to get there. The question then is going to be, though, what does primary care do? And now I think what we're going to see is that there's two big opportunities. The first one is to take care of those patients for whom the generative AI tool can't. And these are people with multiple different tools. These are the individuals with multiple different problems, multiple different chronic diseases, who need to have a human to sort it out, where there isn't any easy algorithmic answer, there isn't a straightforward approach. And I think today they get shortchanged, and as a result, they don't get well controlled, not because, again, clinicians don't want to do it, they just don't have the time. So the first thing I think they can do is expand and be able to focus on the people who are going to benefit the most. But I think there's a second part, and I think primary care should be getting ready for this. And that is that right now they send a lot of patients to specialists, not because they couldn't take care of the problem. They just don't have the time to do so. And I want to add another piece on top of that. The generative AI will provide an added expertise. And when we looked at this inside Kaiser Permanente, not using a generative AI tool, but using a different type of approach, we found that about 40% of the problems that get referred to specialists could be managed by primary care if they had the time to do so. And I think that that is what we're going to see. We're going to see an evolution in physicians practicing primary care. They're not going to be doing the routine algorithmic problems that today take a moderate amount of their clinic and office time. They're going to be expanding into the most complex patients on one hand and going up the complexity hierarchy, taking on a lot of the outpatient, not the patients who need a procedure or a surgical intervention, but we're talking about the patients who require some type of more extensive diagnostic workup and some sort of ongoing treatment. And I think this is what is going to become the future of, I'll call it internal medicine as practiced in the older days. I think we're going to go back to that, supported by a generative AI tool with the clinicians having the time necessary to do so. But I think all of that will also require in parallel that we have some type of evolution in payment. As long as people are getting paid on a piecemeal basis, on a fee-for-service basis, to pay for volume, we're not going to have the ability to give the kind of attention we should to, number one, the kinds of problems that are more health-related, preventable. These are not the kind of areas that we're focusing on, and we're not going to be focusing on the opportunities in the healthcare system to be able to lower the costs. The statistic I keep focusing on these days comes from the CDC, and based upon its data, if we could control chronic diseases as well as the best programs do today. Now, the best programs are doing it often with a lot of people and a lot of costs. But if we could use generative AI to accomplish that, we'd eliminate 30 to 50% of heart attacks, strokes, kidney failures, and cancers. Now, I want you to think about if we had 30 to 50% fewer of those diseases, we could save between $1 and $2 trillion a year. We could do so much with that money because we would have generated it, not by skimping on care as so many insurance companies are doing today, but by preventing complications, preventing the need for procedures and admissions, by keeping people healthy. And I'll tell you, as a patient, that's exactly what I would like.
I absolutely agree with you on that, Robbie. It reminded me of another related topic, and that is, how do you see robotics evolving? I mean, robotic surgery, is there a day when you can have the surgeon at Harvard doing your surgery in Kansas, for example, through a robotic interface? Do you see that day coming?
Well, I'm going to go one up on you. So let me first talk about the question you posed, because that's a question I posed probably 15 years ago. And when I studied it in greater detail, what I found actually is although Kansas and New York are separated only by a couple of thousand miles, that makes the robotic surgery very hard because there's a slight time delay. As fast as the electrons move, and even though it's such a small time delay for the human brain, it's actually quite problematic. So I don't see that happening. But what I do see is the surgery being done by a generative AI tool. I mean, think about it right now. You look at a current operative robot. How does it work? The surgeon actually sits at a console 10 feet away. The individual's not at the operating table. They're looking at a monitor. Information comes in off of cameras that are inside the patient. And then the individual makes hand motions and moves levers in order to be able to get the robotic hands to do what we want. That's a simple stimulus response. When you ask a generative AI tool a question, that's exactly what it does. It takes the question and it figures out how to translate that using about 2 billion parameters into an answer. And I think that at some point, what we're going to see is robotic surgery being done by a combination of an intraoperative robot with a generative AI application. And I think if we trained it on the best surgeons, we actually could, again, get better results than we're able to get today. Now, that's not a 2 or 3 years. That's probably about a 10-year process for a variety of technical reasons. But that's not necessarily such a long part. Now, when I tell people that, they say, oh, no, surgery is too complex. What about all the anomalies? Well, first of all, the generative AI tool knows every anomaly. It can study 1,000 anomalies, whereas no human surgeon is able to accomplish that. And then I say, okay, let's just compare the example you said earlier to the self-driving car, the Waymo in San Francisco. All of a sudden, something's coming out of the side. Is it a ball? Is it a piece of paper? Is it a child? We don't know. That doesn't happen in an operating room. Yes, organs beat and other things happen, but that's kind of unpredictable circumstances driven by external factors. There's no wind in the operating room to blow things around. There's no kids on bicycles or whatever the pieces may be. It's far more controlled. And I think that essentially in the same way that the human brain is able to look at this image and pull the levers and move their hands, we will be able to accomplish that with the technology sitting in place. And so again, I think what we should have to understand, it's not going to totally replace the surgeons. If you had prior abdominal surgery, you have a lot of adhesions. This is not a common problem that can be handled through a common solution. In that way, I'd say the roads are going to be easier. But I think we could take the patients who need their gallbladder taken out, and it's never been, the abdomen has never been operated upon before, and it can be done with a higher degree of safety, avoiding the kinds of abnormalities that then lead to a complex problem when the wrong duct is tied off, leading from the gallbladder to the intestine.
I'm fascinated by the delay problem, and I'm also fascinated by the leap forward that you took with that example. I wonder now that we're talking about this, if you can give me some insight on the regulatory barriers to the implementation of all kinds of AI, and how do we begin to fix that? Is there anybody beating that drum about how are we going to change the regulatory environment so that it's supportive of AI strategies?
Well, a lot of people are working that. The current administration in Washington, D.C. has at least talked about that. The head of Medicare and Medicare, Dr. Oz, he's talked about some of the opportunities in rural parts. He's talked both about the opportunity to create bots for people living in rural areas of Montana and Wyoming, He's talking about the opportunity to use ultrasound. There's no OBGYN doctor to do it. We could use a technology to accomplish it, to provide ultrasound care to pregnant women in Alabama right now they're looking at. Now, will these things happen? I don't know. But what I want to stress is that the way the FDA has traditionally approached, I'll say, these kinds of tools is the way we do medications. What it wants to see is, okay, how is it developed? What are the safety numbers? Give us a study of X thousands of people in order to qualify. Show me if it's been an AI tool, show me the data set it's trained on. Generative AI, that's not how it works. It's so dependent upon the prompts that the patient gives. It's you can't really look at how it's trained because it doesn't get trained. It just has all the literature that's ever been written on a given topic. It has billions of parameters, way too many for any human to analyze. And then it applies that to be able to figure out what is the piece coming out of the literature that now specifically answers the question that's sitting in place. We have to get way past this idea that it's just simply predicting the next word. If that was the case, we would never write anything that's coherent. I've had it develop 11-page contracts for me, and it's been perfect. When I show it to the attorney, they say, yeah, this is exactly what I would have done. This is a very, very, very different set of tools. So how do I think we should train it? I think the way we train it is we do tests against humans. We take, let's say, patients calling an advice center, and we have them talk to either a human or a generative AI tool. Obviously, the patient needs informed consent. And we take the answers that come out of that, and now we have clinical experts look at this two set and say which one is better. And we don't approve a generative AI tool until it's 10% better than a human. And this is where I think the fascinating issue is going to be, because if independent observers have found it to be 10% better at providing advice to real patients, how can we not justify approving it?
Yeah.
And that is what I think we need to be doing. And I'm going to predict that when we do that, whether we look at chronic disease management, whether we look at advice, whether we do it potentially at surgical management of straightforward cases, I think what we're going to see is it's going to be as good or better. And psychologically for us as humans, it's going to be hard to admit it, but we need to do so. It's no different than way back when the steam engine came in. Humans were strong, and they were saying this machine, the early machine, we're talking about a couple hundred years ago, could never be as strong as the strongest human. And of course, today it's lifting aircraft into the sky and rockets taking it to moon and Mars and beyond.
Yeah. I fascinating future ahead of us with AI. Somewhat scary in many ways for those of us who didn't grow up with it, but it's coming whether we like it or not. I want to change topics a little bit now and talk a little bit about, and maybe with reference to AI, how does our reimbursement system in this country help or hurt the evolution of AI?
Well, I don't think it's a question of how does it help or hurt the evolution of AI. I think the question is how does it help or hurt our clinical outcomes for patients, of which generative AI is just one example of the areas. And I think that's the biggest problem. I think the pay-for-volume system, the fee-for-service, is an outdated solution that worked maybe in the 20th century, at least, the first part of the 20th century. It just doesn't work today. We need to have a system that's going to reward people when they prevent disease, keep people healthy, avoid complications, provide safety, and none of that is done in a fee-for-service type world, or very little in a fee-for-service type world. What did Charlie Munger say? He said, tell me your incentives and I'll tell you the outcomes you're going to get. Warren Buffett's previous partner.
Right.
Those are the incentives. And it's, by the way, it's not that doctors intentionally want to do more, but when you have to establish priorities, when you have to structure your interaction with the patient, and you know that your payment is going to come by being able to document 52 different things rather than 44 different things, that's how you spend your time. And you have no more time left to do the other parts that sit in place. But I also think that there's a lot of language we need to change. Going back to the generative AI tool, we should never use the word AI, because the old models of AI, what's called narrow AI, that took two data sets and compared them, is completely different than generative AI. Yes, the fundamentals way down deep have a lot of overlap, neural nets and things like that, but essentially it's being developed differently. And what I want to differentiate is tools that we call capitation, which are done at the insurance level, are completely different than ones that are done at the physician and hospital level.
Yep.
And with a few exceptions, almost all of what we call capitation in the United States today is being done at the insurance level, or 10%, 8%, 4% of some kind of quality measure or something having to do with patients. There are some, and I will call them pay for value type programs, ones through Medicare. There are programs like a Kaiser Permanente that are able to provide the care in a capitated type way, but there's just not very many of them in the United States. And I don't think it's because it won't work. I think it's just very hard to make the transition. I often think about that as standing on one side of the Grand Canyon, and you look across the other side, you say, well, I could probably hit a golf ball across it or something. But then you realize if you had to go there, you got to go, a mile or two down, and then a piece across, and then another couple of miles. It's a massive hike. And that's what ends up happening. You got to create medical groups, because no individual doctor can take capitation. And it's got to be medical groups that go across specialties as well as primary care. And you have to do the organization in a way that they're able to establish a leadership. And you can't have a transition, because every time you have a transition, people will prioritize the fee-for-service patient who will pay more today to the capitated patient who hopefully will pay more tomorrow by avoiding various diseases that may be coming along. I often think about this one, I'll say highly respected, so I won't mention the name, organization that had two doors. One door into their buildings of the health system was for fee-for-service patient, and one was for capitated patients. And you can guess which group got the attention first. So that's the challenge that we have. The system is completely broken. How we pay doctors is completely broken. And I think the people who are getting hurt by it today are the patients. We're not going to solve the problems of medicine by either cutting back. We're not going to solve the problems by simply doing more. The way to solve the problems is to keep people healthier, to prevent chronic disease when we can, but more importantly, by which I only mean it's just more common, to manage it. Control hypertension, we have 40% fewer strokes. Control diabetes, we have a significant decline in cardiac problems and kidney problems. We can go down the list of opportunities that are there. Look at GLP-1 drugs right now. That's a big opportunity to avoid obesity and diabetes, to avoid obesity-related cancers. We could go down all the pieces. It's not that we don't know what to do. We just have not figured out how to move from the 20th century into the 21st, and we're already a quarter of the way to the 22nd.
Yes, we are. Well, the pushback that I've heard on this is that, well, yeah, there are problems with fee-for-service. Obviously, at the margin, people are incentivized to do more. You can't do anything you want for the patient because you only do what you get paid for. So there's a code for that. You can do it. If there's not a code for that, you're wasting your time that could be spent, coding. The pushback on capitation is that, well, the incentive is to do less. And then the solution, and by the way, this is the primary problem in my mind with capitation at the insurance level. Often what the insurance company does is pay fee for service and then have a whole slew of metrics that they will use to try and meet the the capitation or the work RVUs, however you want to do it. It's basically unit work instead of overall quality. So how do you tackle some of that pushback that, well, yeah, but if you just capitate, then the incentive at the margin is to do less or maybe less than enough for each individual patient? What's the solution to that problem?
The solution is the contracts are not 1 year, they're 5 years. The solution is basically that we will pay you the same rate we're paying the doctors in the community taking care of equivalent patients who have fee-for-service coverage. But after 5 years, we will look back to see the utilization that happened, and we're going to share in the savings. I mean, one of the things about physicians to realize is they're very, very smart. If you have to pick someone to take a test, pick a doctor. They are very skilled at doing that once they understand how it's going to be measured. But essentially, if they know that 5 years from now, they're going to have this opportunity to earn a lot of money by being able to keep people healthier, by reducing heart attacks and strokes, by minimizing complications, by keeping people safe, these are the opportunities. They're going to figure out how to do it. We should, doctors say, well, just trust us. Well, the reason insurers have prior authorization requirements isn't that they don't trust doctors. They know what doctors are going to do because they have the data.
Yeah.
On the other hand, as soon as you capitate them, they're not going to delay. If you want to delay care and I don't see you, and instead of being able to diagnose your colon polyp early and be able to take it out as an outpatient, I now have to give you chemotherapy for $200,000. I'm a really smart person. I'm not going to do that latter. I'm going to take it out early. I'm going to make sure I screen you. You look at Kaiser Permanente. The death rate from cardiovascular disease was 30% lower in the community. The death rate from colon cancer, 30% lower. How did it happen? Because 90% of people got screened. 90% of people had control of their chronic disease. Because that's what the economics said. And essentially, I think that if once is capitated at the delivery system level, hospital administrators are smart people too. They're not going to continue to try to fill their beds when they know they'll make the biggest money 5 years from now by being able to keep people healthy, by actually reducing it. They're going to shift from inpatient care to community care to outpatient care. They're going to shift from simply trying to reverse disease to preventing disease. They will embrace generative AI tools. They will embrace telemedicine. All the opportunities will happen, not because we're talking good people versus bad people, only because we're talking about smart people who, with the right incentives, will make the right choices that align the desires of the payers with the desires of the providers, with the desires of the patients.
So Robbie, why can't we make that so? In other words, Kaiser Permanente has shown with your tenure there for sure how it's possible. I remember Kaiser attempting to expand to other markets very clearly. I'm sure you were around for some of that. The evidence is right in front of us. What stands in the way of spreading that methodology across the country?
The biggest thing is it's just hard to do. I mean, you're absolutely right. Kaiser Permanente failed. There's 5 regions that went out of existence. And why did it fail? Because it couldn't attract enough patients or hire enough physicians and have enough hospitals to truly provide that. And when you start to, in essence, if you're going to capitate the insurer, which Kaiser Insurance Company is an insurer, but you're not going to capitate or at least integrate and coordinate the care delivery, but instead you're going to essentially pay doctors fee for service, you lose all the advantage. In fact, you actually make things worse.
Yes.
That's when you have to put in place prior authorization restrictions, because each of the clinicians isn't going to maximize what's best for the patient long term. They're going to maximize what's best for themselves in terms of their office. Again, not because they're bad people, but because that is what incentives do. I teach at the Stanford Graduate School of Business. And every industry, we look at incentives and recognize what it can do. And somehow in medicine, we think we're immune to have our behaviors change. It's not because we're bad people or greedy people. It's simply because you're trying to structure your day and you're going to structure it around the rules and the systems we're in. And the rules and the systems we're in are called incentives.
My next question is, if you were going to do one thing that would start to write our trajectory so that we're headed in the right direction today, what would it be? What's the one thing that we can all focus on that's likely to give us a shot at this, Kaiser Permanente strategy of capitation at the level of the doctors and nurses that are actually providing the care, that will get us to the smart use of AI without all of the regulatory burdens? I know there's a million things that have to happen to make that happen, but if there's an area of focus, what would you recommend that be?
Well, first, I think Kaiser Permanente is a good example of an organization that has made progress in that direction. And I think it has a lot of things to be very proud of. So I don't want people to be thinking that I think it should be Kaiser Permanente for the nation. I think Kaiser Permanente has a lot of lessons. It's also had times when it's not done as well as it should. And I think it's just a good learning experience. But what I do believe is that an integrated, capitated, technologically enabled, and well-led organization are the four parameters that are essential to get there. So what's the first one? The first one is moving to out of fee-for-service into some form of capitation. As I said earlier, the big challenge is how do you make the transition? That's why we can't do it at a broad level. That's why policy can't work. What we need to be able to do is to figure out how can we do it in a variety of pilots. How can we find areas of the country that are willing to make this with groups of clinicians? You need to have probably at least 250,000 members, and you need to probably have at least 1 to 200 physicians, as well as a whole lot of other staff in order to support the process. And you need to have a 5-year long-term contract. And I would hope that the government would do it through Medicare and Medicaid, or through, I would hope that self-funded insurers would be willing to do this. I would hope that some insurance companies. And so that's what I would see us doing. I don't think we're going to solve 20% of the US GDP, the largest in the world. We spend more on healthcare than every nation in the world spends on the totality of things for its citizens, with the exception of China. Let me say that again. We spend more on healthcare than France spends taking care of all the people in France, or the Great Britain, all the people in Great Britain, or Australia and all the people in Australia. That's how much we spend on it, $5.6 trillion. We're not going to shift that in 1 year. But I think that if we keep waiting, we're going to get to a point where we're not going to have any choice besides to ration care. And that's my big fear. Because at some particular point, it just takes too long to make the transition. And we're going to find ourselves at the national level, the debt that we have, the interest payments that we have to make, being so great that we're going to have to take radical steps. And having taken the radical step, we're never going to go back and do it right. This is why now is the time to do that. So I would say over the next 5 years, we need to have enough pilots in enough locations to be able to demonstrate not just that it's possible, I know it's possible, but how to do it. What are the lessons going to be learned? I mean, places like Kaiser Permanente, it has an 80-year history. It doesn't have to build it quickly, but that's not an opportunity everywhere. But again, as soon as we acknowledge the failure of the current system to provide the quality that's needed, and still we start to acknowledge the fact that half of Americans can't afford health care if they became sick. They couldn't pay their deductibles. The average business, we're talking about small businesses, they spend on average $25,000 every year for a worker, a spouse, and 2 kids, a family of 4. 25, that's giving a worker a new car. Try to think about that. If a worker is going to be earning $70,000, $80,000, that's a pretty average salary in the United States. And they're going to spend $25,000, a third of their salary on health care, or a third of the salary they should have on health care. It's just a recipe for long-term disaster. And things are getting worse. What we know is that healthcare costs are rising over 7% a year. You have to put that into a context. How do you pay for healthcare? Well, one way to pay for it is what's called gross domestic product. The dollars that we have to spend on people or the dollars that we generate, that's going up 2 to 3%. Another way to look at it is to say, well, what's happening with wages? They're going up maybe 3 to 4%. Another way to look at it is what's general inflation? That's also sitting under 3%. You can't have one segment of the economy going up 7% at a time when people are struggling financially and economically in the United States today, which they are, and expect that that system is going to be viable long term. And the sooner you start to acknowledge it and then address it, the more likely you are. And I think the first step is to have these pilots that are truly capitated, that have effective leadership, that bring together people from various specialties and apply technology and have a 5-year contract around it. I think that's when we're going to start to see a lot of success and the ball will start moving. And the faster it goes, the more momentum we'll have. And at some particular point, maybe it'll take a decade, maybe even a little bit longer, but we're continually making progress there rather than if we stay committed to fee-for-service and we start moving in the opposite direction.
Yeah, I cannot agree more, Robbie. And I would argue that, we've been saying for years that the current rise in healthcare prices is not sustainable. And people ask when we reach that point. I think we're there. And I think the impact that it's had on the broader economy is evidence for that. I mean, the dollars that are spent on healthcare don't go into the paychecks of the folks that are working those jobs in small businesses and factory, wherever. Those dollars are going to healthcare instead of into their pockets. And so I think we're there. And it's one of the reasons that we have the economic crisis that we have. We just refuse to look at it clearly. I wonder, there's one more topic I wanted to get your take on because I think it's fast. Well, actually, there's a couple, and they're related. Though, what's your opinion on the movement towards direct primary care? How do you see that, and where does that fit into the puzzle?
I think direct primary care is a movement in the right direction, but you got to realize you can't afford direct primary care unless you're in the wealthier segments of the population. Why do I say that? Because you have to pay for it out of pocket, which means post-tax, and
you still need insurance. Yeah.
Well, I'm saying even if you have insurance around it. But why do I say it's in the right direction? Because that's what I think everyone should have. The problem is how do we construct a system where everyone has the equivalency around that? That was my view, actually, when I was a CEO in Kaiser Permanente. It's why we paid more to primary care to recruit them, to have enough physicians. It's why we lowered the panel size probably to a third, 30% lower than the rest of the country, or maybe even more than that, because we could understand that when you give primary care the time and they focus on preventing and managing chronic disease when they solve the problems at the first visit rather than multiple visits in order to get there because they don't have the time to address all the issues, that is where the real opportunity is going to come. So I think it's a first step, but it's not a last step. It's a step that works if you have enough money. Because you have basically a concierge who's going to direct you through it. So I have nothing bad to say about it, except that I think that the majority of Americans simply are not going to be able to afford that cost. It's what we should be doing, by the way. We only spend about 5% of healthcare on primary care. We should be probably close to about 8 or 9%. And if we did that, we would now have the ability to lower panel size, to provide better assistance, and to move to a variant of that. And then we would be able to energize it by using a generative AI tool, able then to accomplish longer term control with 30 to 50% fewer heart attacks, strokes, kidney failures, and cancers.
Yeah. I once again, I agree. This takes me to the final topic I wanted to talk about with you, and that is, it's related in that because of that lowered panel size, fewer patients to take care of. They have more time to take care of the patients that they have in, obviously in a direct primary care situation, or apparently Kaiser. I didn't know you had reduced the panels by that much, but it makes sense. How important do you believe the healing relationship, the patient-physician relationship is. And, I'm always fascinated when I read about the placebo effect, how powerful the placebo effect is. And I think most people don't recognize just how powerful that is. And I think that that's a big part of that healing relationship between patient and physician. Is that one of the reasons that we need to get back to a direct primary care or a lower panel size? And if you have thoughts about how AI, large language models, or other AI strategies might impact that, I'd be interested in hearing about that too, because it seems to me like that's a fundamental reason so many of us went into healthcare.
Yeah. I'm a big believer in the doctor-patient relationship. I'm a big believer that it's essential. And if I find myself at some point in life with some terrible disease, I'm not going to want to talk to a ChatGPT, even if I know the information is going to be great, because I want a human-to-human context. I think that we often miss the fact that a lot of the biggest problems in medicine today go beyond direct healthcare. If you look at the contribution that various societal factors have, you look at the contribution to chronic disease, it's significantly more. And there's not a computer system that's going to be able to address that. It requires an individual. I said before, individuals who have complex, multi-disease type problems. They have a heart failure combined with a kidney issue, combined with a mental health issue. That requires a human to try to sort through it. And we've given that task to primary care, but we've never given enough time to take care of it. We don't recognize that. Talk about end of life care. I mean, that's not a conversation you can have in 15 minutes. So I'm a big believer in it, but I think right now we make that impossible. Unless, again, if you have enough money, you can buy that time, in essence, is what you're doing. But if you don't, if you're the typical American, then you simply can't get that done. And so I think, again, we trip over our own feet because we give a lot of care that people really don't want, as an example, and we don't do the care that people actually do want. We don't ask them the right questions. Atul Gawande has written extensively about this. Great books by him about, what is it that you want as an individual, and how can I help you to achieve that? That is the caring part of medicine that drove us all to become clinicians in the first place. And if you don't have enough time, you just simply can't do that. And that's what we see today. And yes, I see generative AI taking over a lot of the things that could be done just as well as us. And if we can do that, then we can create the time. If the kinds of day-to-day problems can be addressed by a generative AI tool, if the kind of chronic disease management for most people who have straightforward one or two chronic diseases, not terribly out of control, but not fully in control, that's where the opportunities are with the generative AI tool. And that now frees you to take care of the really complex patients. And it frees you to be able to take care of more of my problems because you now have the time in your day-to-day work to do it. And as you've noted earlier, you have to balance the economics around it, because in the book ChatGPTMD, I write the fact that any technology that either slows doctors down or reduces their income, it's not going to be embraced. And it's not because doctors in any way are bad people. That's just human nature. You're not going to erode your own family except in the highest of crises, pandemics and other types of crises that are out there. And we all do that. But I think overall we need to create the fertile soil. And today we have not done that. I think a generative AI tool could do that. And I think the time has really come for people to prepare for that. We need to retrain people in medical school and residency. Their job is not going to be simply responding to the call to the ER to unblock a coronary artery. We're going to have to figure out how they can help us prevent that artery from clotting in the first place. And in doing that, to be able to be assured that they're not going to be personally harmed as a consequence. If I had to say one thing that's really missing in medicine today, trust. I think that trust has been eroded. I think the trust between providers and insurers is an example. I think a lot of individuals who are signing up for private equity or working for hospitals have realized that it's a deal with the devil. And that trust is now eroded. I think patients and doctors are starting to see that trust erode. That's what the data says of interest. We've seen a significant drop over the past couple of years. A lot of it because of prior authorization and other insurance-imposed restrictions, but a lot of it simply because patients are coming to conclude we don't care, when the truth is we care a lot. We just don't have time. And so that's where I see we have to go. I think technology is a means to get there. And I'll tell you, I wish I could tell you a different way to get there. I just don't know what it is. And that's why I think technology will be our last and best hope. And we need to figure out how we can use it, not protect ourselves from it, but use it on behalf of our patients. And I go back to the same thing. The combination of the dedicated clinician with the empowered patients in a generative AI tool will achieve exponentially better results than any of the three alone. That is the new reality. And the sooner medicine grasps it and implements it and embraces it, the more likely we are to be able to do what we've dedicated our careers to preserving the health of our patients.
Robbie, I tell you, we usually have a final question, but you summarized that so beautifully. You just answered our final question. So I really appreciate the time that you've given us today. It's been such a pleasure to talk with you. I always enjoy your insights. Can you tell everybody where they can get more Dr. Robert Pearl? Where can they find you online and benefit from your wisdom?
The best place to go is to my website, robertpearlmd.com. And there people can find access to my monthly musings. And my monthly musings comes out once a month, the second week of each month. And it has a plethora of information, of opportunities to be able to read articles, to listen to podcasts, to be able to see videos on a variety of social networks. It's all subscription, cost-free and no advertising, and it's really designed to educate the American populace. I believe that American medicine should be the best in the world. It has the best people, it has the resources, and I invite everyone to come along on the journey and let me know your thoughts. Go to the website and send me the information. Thank you for having me today. I love your podcast. I look forward to the next time.
Ladies and gentlemen, Dr. Robert Pearl, philosopher, physician, friend, just an amazing breadth and depth of experience. Such a great pleasure to talk to you today. We'll see you next time.